Hi, thank you so much. I'm really excited to share all this, one of the most exciting field in medicine with you. Just a quick, kind of an overview. I went to UCLA for medical school and got a traditional medical education. I was doing regular medicine, and then, of course, there's a lot of frustration. If I'm sure you've all heard. And then I found out people were actually doing stem cells, and that's a lot of doctors simply don't even know. So when I started doing it, I just found tremendous success with my patients. So I'm transforming people's lives. So that's how I became really passionate. So I just want to kind of share what I've learned with you. I'm in Los Angeles at Thea Center for Regenerative Medicine. And I want to talk about what stem cells are. First of all, so there are three qualities that qualify something as a cell as a stem cell. So first one is that it has to be able to self-renew. So the cells, they divide, and there's an asymmetrical division. Every time they divide, one of the cells will be exactly the same as the original cell, and the other one will be the differentiated cell. So that's the second capability, its ability to differentiate. So to wherever the tissue they're at, that they're able to differentiate into that particular cells of that, making up that particular tissue. So then they renew the tissue. When the tissue is injured, there's any kind of cell death, then they can repopulate. And this can be a little busy, but I just think it's important that people know the nomenclatures and kind of get a better idea of what people are talking about. There are different kinds of cells. So when people say stem cells, there's so many different kinds, just because it's stem cell, but they all have different properties. So starting from the very, very primitive, then they're precursor cells. They're uncommitted with very long telomeres, so these are very vibrant. And the totipotent basically can form everything that's, since the conception, so the embryo, placenta, and sperm and egg. And the pluripotent can form everything except for the placenta and sperm. So that you hear people talk about the induced pluripotent stem cells. So those are the cells that's able to form any cells of any tissue type. And then you have the multipotent, the germ layer cells. So they are in development, we all know the embryo goes, develop into three layers: ectoderm, endoderm, and mesoderm. So these, within each derm layer, they have multiple potentials to become the tissue of that layer. And then when you come to a little bit more committed, so they're going down their evolutionary pathway, they become more committed, so they can't become everything that the previous generation can become. And but they still have more potential, but then as they divide, as they differentiate, they become less and less. From the tripotent to bipotent, unipotent, so they just become narrower in their ability to become certain types of cells. And so this just to give people a general idea. When the embryo, when the fertilized egg, it's really our first stem cell. So we all came from stem cells. So that's our first stem cell. And then it divides into four-cell stage and morula, and then became blastocyst. So when you have the blastocyst, so this is the inner cell mass. And when people talk about embryonic stem cells, that's what they're getting. So they're taking one of these cells and expanding them, and that's the embryonic stem cells. And that's not allowed for clinical use in the US. It's only for research. So the different layers, it just is a little bit more detail. And then this is very detailed, but I just want to give you a sense that how much science has evolved and all these markers. So these are totipotent stem cells, and they have certain markers that you can tell that makes them totipotent. And then when they differentiate more, their different surface markers start to show up. That's one way that they can tell what kind of cells they are. And again, similar, so the blastocysts, very, very early on, the epiblast-like stem cells, and they differentiate into the three layers. And then each one, the ecto stem cells will become, these tissue-specific type of stem cells. So multipotent, tripotent, bipotent, unipotent. And so again, similar, just want people to take a look. The ectoderms, outer layer, become cells of the skin, of the nervous system, neurons, and mesoderm becomes the spinal cord, skeletal, kidney, blood, and the endoderm, the pancreas, thyroid, and lung. This example. So this is, very similar. Just give you kind of a little bit more detailed breakdown of what becomes what. And so this is a blastomere. And these tiny little cells are blastomere-like stem cells. And these are epiblast-like stem cells. So these are they have pluripotent potentials. So these actually, there's some evidence that these may persist to adulthood. So that's another area I think is very exciting, and there hasn't been enough done about it yet. So I'm always looking for what's who is at the forefront and gets to the. If we can get the pluripotent stem cell that can become anything and transplant those in our body, that will be ideal. So endogenous stem cells. So that's just cells that are within our body. So we have different markers that actually shows that these are pluripotent stem cells. So I just find it very interesting that they have found all these different cells now in the human body that actually have pluripotent potentials. So now I want to talk a little bit about the classification. So this is a very common classification, of cell therapy. So autograft is when you get your own, derived from your own tissue, and then you put it back in your own body. And allograft is from allogenic source. That means from one human to another. And then the xenograft, which always surprises me that how many countries are actually doing this, especially I know a lot of Southeast Asia countries are doing that. To me, it makes no sense because their genome is very different from ours. When we have perfect human stem cells, I don't see why we want to use a foreign animal cell. So another type of division would be embryonic stem cells versus adult stem cells. So embryonic, I talked about, and adult stem cells can be bone marrow derived, which has the longest history. The first case in 1956. And then, or it can be adipose derived. It's a little later, so first discovered in 2001. And then the perinatal. So even though it's perinatal, it's right around the time the baby's born, it's still considered adult stem cells because these are way more adult-like than embryonic stem cells. So their properties still are settled in some way. So they don't have the kind of potential like embryonic stem cells to go haywire and generate teratomas and start, have tumor formation. Because these perinatal derived stem cells, even though they're very young, they're still adult, they've gone down the pathway, the evolutionary pathway long enough that they will not go haywire. They've lost that ability to become anything and just start to reproduce. So embryonic stem cells, I want to talk a little bit more. So the sperm and egg, fertilized egg, and then it becomes a blastocyst, and then they get cells from the inner cell mass. That's about 5 to 7 days after fertilization. So they culture that, and they can induce the cells to become different cells of the tissue. But one problem is that there still hasn't been enough control of their destiny, because there are still cases of people having tumor formation at different strange locations. So that's why is it too loud? That's why the U.S. has not given permission for it to be used clinically. And so bone marrow. So that's a bone marrow aspiration, usually at the hip, iliac crest. Pretty painful procedure. Some doctors say they can do it with less pain, but it's still a painful procedure. Also, I always wonder, there's a concern. You have certain supply of stem cells. When you keep taking it out, you are depleting. You are depleting your regenerative resources. And then this is the liposuction where they get it from fat. So when they get it from fat, really what they're getting is from the blood vessels in the fat. So the fat is very well vascularized, type of tissue. So they're spinning it down, and the stem cells are mostly what they're getting is the MSCs, mesenchymal stem cells. And when they're hovering around the blood vessel, they're called pericytes. So right around the blood vessels, pericytes. So when they're spinning it down, really they're getting those pericytes. They're getting those perivascular stem cells, and they're using that for regeneration. So for a person that's younger, that has some fat, it can work really well. There are a few concerns. One concern is if you get liposuction, actually different fat from different areas have different properties. Here is not so good. It's more toxic buildup. These areas are actually better. But so there's limited supply, but when you get cells, when you injure, so I don't know how many have done liposuctions in this room. Nobody? It's kind of brutal. It's not pretty. They were doing, expanding the tissue. They were, washing it. And so there's, when you look into the tissue after it's done, you put a little camera, it's a lot of damage. So it's significant injury that you're causing. And then you're taking those and you're getting the stem cells out of them, and then you're reinfusing it, IV or particular locations make more sense. But if you reinfuse into IV, these stem cells have intelligence. They're going to be attracted to areas of injury. So a lot of them are going to end up right where you tried to take cells out of. So that kind of beats the purpose. But they've got, a lot of research have shown good results from these cells. They're a large percentage of MSCs, the perivascular cells. They, especially for people who are younger and healthier, but when, I want to give you the statistics. So MSCs in the body, when you're born, it's about 1 in 10,000 of your cells are MSC. So they're distributed throughout your body. And when you are in your teenage years, it's already dropped down to 1 in 100,000. And when you're in your 40s, it's dropped down to 1 in 400,000. And when you're in your 80s, it dropped to 1 in 2 million. So there's a sharp decline in the number of these cells, but not only just the numbers, but also their ability to produce different factors and to be activated and to start regeneration. So they're becoming more and more sluggish. So they're not doing a whole lot. So not only the number, but also the quality of cells decline. So that's one concern with fat-derived stem cells. A lot of doctors are doing that. The majority of the doctors doing stem cell treatment are using fat-derived or bone marrow. So that's using autologous sources. What I hear is that the results are variable. Sometimes it works, sometimes it doesn't. So it was a little frustrating. And that could be why. Also the processing. So you're processing it in your own clinic. You're not a laboratory, but you're learned, from a course you took and from the manufacturer, you're learning how to do it. So that's, that could introduce a lot of variabilities, as far as the operator, what they are able to achieve. So that's the fat-derived. And, I got something cut off. That's okay. So, so that's what they do. They get the fat and they spin it down, and the stromal vascular fraction, that's what they use. That contains a lot of the stem cells that they use for joint injections and various treatments. So we talk about what the advantages are of using your own cells. Of course, it's perfect match to yourself. So if you do put a stem cell in yourself in a particular tissue, yes, it's possible that stem cell can differentiate and become part of your tissue. So then they're not going to face any rejection. So that's the perfect match and probably stay in your body longer. And the disadvantage will be that it's invasive and inconvenient, that there's risk of infection, which I've heard from other doctors, no matter how careful they are. And then with age or disease conditions, the quality declines. And so, like example, the red marrow start to change to yellow marrow when a person ages. And the cell quantity is inconsistent when they do the procedure. And the stem cells are less potent with shorter telomeres and less generation remaining. So I have quite a few review studies comparing the MSCs from the birth tissue versus from bone marrow and fat, they've actually found that the MSCs from the umbilical cord, or from the birth tissue, produce more anti-inflammatory factors. They are more robust. They don't get old and die as easily, and they have more neuroprotective functions. Metabolically, they're just more active. So there are many parameters that they show that these are superior in many ways. So that's the perinatal source. So we've got the fetal tissue, so the placenta, and this is the cord. So the chorion is part of the baby. The mother. The amnion is the baby's tissue. So the placenta, that's when a baby is born, you will hear about these companies that have umbilical cord derived stem cells. So what they do is that they can work with the hospital, and supposedly they're only supposed to accept placentas that have been obtained through C-section, because that's a complete sterile environment. It hasn't gone through the birth canal. So they want a complete sterile organ. And then it's gone through all kinds of screening. It's the same level of screening as organ donation or blood transfusions. So they go through the same kind of infectious disease testing, and the mother is monitored, and there's entire history taken. So this is only after a mother has agreed to donate the tissue, because some mother, they're always asked, do you want to keep the cord, keep the blood, or do you want to donate? So majority of them actually says they don't want to keep it, because it takes $2,000–3,000 a year to store the cord, and they're just not sure of the value, and so majority of them say no. And then they're asked if they want to donate the cord, and if they say yes, then they're asked to fill out this very long questionnaire, over 80 questions going over their own health history, their family history, their travel history, partner's history, the prenatal history. So everything is screened. So depending on the different labs that's doing this, some may accept lesser products, some may only take the most high quality. So not every baby is the same. It's pretty fascinating. A tiny mother with a normal weight baby can have the biggest cord, with the most producer of stem cells, and some a big person may just have a long skinny cord. So you never know. It's very interesting. The cords, every cord is different. So talking about the advantages and disadvantages. So the disadvantage, of course, is that there's a potential immune response if you give somebody someone else's tissue. So when these cells are separated, because when the transplant happens, is stem cells. So within stem cells, there are very few surface markers. They're very, very small cells, only a few microns. And they haven't developed surface markers to really mark them as a different individual, Mary or Joan. So when they're transplanted into another person, it looks like a blank cell to that person's immune system. So the immune system says, well, that's just a cell. It doesn't say anything, so I'm not going to try to destroy it. So the problem happens when the cell tries to differentiate. That's when they start to go down their pathway, and they may express different markers, and then there may be something that's different. And then the immune system says, oh boy, that's, you're not me. But interesting is, in the past, a lot of people, even scientists thought that the way stem cell works is by being put into somebody's body and magically, become, start to reproduce and become the tissue, become the part of tissue, the injured tissue, and that's how they repair. But the new science, there's lots and lots of evidence came out that shows really the way they repair is not by becoming your tissue. It's not by replacing what's damaged. It's really by signaling, first of all, calming down the inflammation so that there's an environment of healing, so the repair can actually occur. And then what it does is it sends out all kinds of signals, bioactive molecules to your immune system, so different cells can come in and help with repair, and also stimulate local stem cells. So what they've done is that even people who have got allogeneic transplant, from another person, and they had a tissue repair, and when they actually analyze the tissue, it's their own cells. So these cells are actually kind of like a master, kind of like a conductor in a symphony, basically saying, do this, do that, and you can repair this. And they eventually die. So these stem cells, when I do stem cell transplant for patients, when I give them these cells, usually the cells probably last in the body for about 3 to 6 months. So the effect, lasts for 6 months. Everyone is a little different. But, on average, about 6 months. That's how long the effect lasts. So stem cells die, just like any other cells in your body. And these stem cells, when they're freed from another source, they have gone through a little bit of trauma. They've come out of something else. So it's a little harder for them to survive. But when they try to go into your inflamed sites and try to repair, they're also experiencing a toxic environment. So it's almost like a soldier. They're going to battle. They're trying to fight the battle, but they can get injured in the meantime, and they could die. So the cells, they do have an attrition rate. So while they're combating inflammation and injury, they could also, kind of be sacrificed. So that's one reason that they just, they drop in number, and then they eventually die off. So there's a lot of advantages. So they don't, they don't, they don't engraft as easily, but now we know that's not the main way they function. And the advantages, a lot of advantages. So there's no matching necessary because I mentioned they don't have the surface markers to really make them foreign, so there's really no reason to match. So they're considered immune privileged. Actually, they have immune suppressive properties. So the MSCs I was talking about, they have done for organ transplants. They have given people organ transplant and they give them MSCs because these MSCs actually help prevent organ rejection. So they actually, so there's opposite effect. I have done a lot of these treatments for my patients, and also my patients who are very curious and want to make sure that this is the right thing to do and they're safe. So they looked everywhere for any side effects and problems, and they finally just said, I can't find any, on the internet anywhere. So because it is exceedingly safe. And then the cells are very primitive. So like I mentioned, little surface markers in the cryopreservation in the treatment process actually make them lose more surface markers. So the cells are younger, they're more potent, they differentiate more efficiently, and they have longer telomeres, so they're more robust. They contain, so there may be some pluripotent stem cell population. So when we're younger, they're going to be more pluripotent stem cells. And they're very easy to obtain, with no ethical considerations, because we're not hurting anybody, because 90% of the birth tissue is tossed in the trash right now. This is the amniocentesis. This is when people get stem cell-like product from the amniotic fluid. So then usually probably the best products is obtained between 3 to 6 months, so early on in the pregnancy. That's when it's more therapeutic. So you've all heard of amniotic fluid-based cell therapy. So there are advantages and disadvantages too. So again, there's a lot of growth factors. So that's one reason it has been very helpful when people do wound healing or local tissue injection. It does work because there are all these growth factors and cytokines, and the cells are very young. So usually within the first, so this is 3 to 4 months, that will be ideal. There may be some pluripotent stem cells. So the disadvantages is that there are very limited number of cells. So amniotic fluid, very few cells actually float around in it. And there's so few cells that the FDA actually prohibits amniotic product to be called stem cell products. And pressing the wrong button. Another thing is, a lot of these amniotic fluid were obtained on people with that are doing amniocentesis. And they're doing it because they're trying to figure out if there's anything wrong with the baby. So then, the people who are doing it actually have higher risk of, having genetic defects. So that's another concern. And then, of course, it's invasive. There's a risk of miscarriage. And then there's ethical consideration. The fact that, are some women going to start selling their amniotic fluid, to get pregnant so they can, start to especially in maybe other countries other than the US. I guess the laws, it's a little harder to control. So are women going to just become pregnant so that fluid can be taken out? So that's another concern. And then we come to the umbilical cord, which is my favorite. So the umbilical cord cross-section. So this is the artery. So there are 2 arteries and 1 vein. And the rest of it, so all this is pretty much gelatinous material that's called Wharton's jelly. And the Wharton's jelly has been researched a lot. A lot of studies have been done on cells obtained from Wharton's jelly because it's very rich in MSCs. So I talked a little bit about MSCs. MSCs, it was discovered by Dr. Arnold Kaplan, and it was called mesenchymal stem cells, which he regretted later, and now he said he's renaming it to medicinal signaling cells, because he said there has been no evidence. I just saw him at a conference just a week ago. There's no evidence that these cells actually differentiate in vivo. So you can get them to differentiate in vitro, on the petri dish, but in the body they still haven't shown evidence that these cells actually divide. What he believes these cells do are actually a master of regeneration. So it's throughout your bodies, everywhere in your body, along the vasculature. And they have significant evidence of how these cells will make contact with local stem cells and send signals and direct their direction, as far as how they should act, their activities. So in a way, they are the conductor in that symphony, right? So they tell the local cells. So they're not so much stem cells, but as a signal, as a controller of regeneration. So that's where the field has moved into, is about MSCs. We hear about MSCs all the time. So that tissue is extremely rich in MSCs. And of course, because it's newborn, it's 9 months old, it also has all kinds of growth factors and all kinds of other interesting properties. One thing about the blood from the cord, from these vessels, the cord blood is very interesting. I don't know if you guys heard about that study in Stanford where they have old mice and that they infuse them with old people's blood versus young person's blood. Have you guys heard of that study? And how the mice that got young person's blood started to regain some of their memory and their liveliness, and they start to move around and doing their maze much better, like a younger mice. So they were trying to figure out what's going on, what's in the younger person's blood that's not quite in the old person's blood. So they found this protein called TIMP2 protein that's really rich when a person's first born, when a person's born, and then when the older they get, the less and less, drastically decline this protein. So whatever that's in that blood, it's very powerful. So I don't know if you've heard of people wanting to get transfusions from young person's blood, with young person's blood, and they should just do umbilical cord blood. That's much more powerful. So again, just a picture. So this is the cord tissue I was talking about, which is mostly Wharton's jelly. And this is the vein and the 2 arteries, and that's the cord blood where they obtain cord blood from. And in the cord blood is mostly hematopoietic stem cells. And the cord tissue is mostly mesenchymal stem cells. So these are very different types of stem cells. So this will give rise to all the cells in your circulatory system, your white and red blood cells and platelets. And these, there's still different kinds of MSCs. They're not all the same. Supposedly this give rise to all the other tissue, but Dr. Kaplan thinks that they're more of a master. So why is MSCs important? So I'm just breaking it down a little bit more. So the paracrine effect it's about the stem cells being in the local environment and sending signals to the cells in the neighborhood and telling other cells what to do. So it's affecting right in the area. So that's what they're able to do. they induce changes in nearby cells. And then immune regulatory, so they have, the MSCs are able to modify or regulate immune function. So causing a shift from a highly inflammatory to an anti-inflammatory type of situation. So like I've treated a patient with lupus, and I gave her 2 infusions 2 weeks apart, and then she went to get her test a month after that. And then her lupus markers, everything came back to normal. And then she was so excited. She's only at 34 years old at the time, and she had 6 inches of new hair growing out. She was like, I got all this new hair, I'm so excited. So it just is remarkable. So that, because there's incredible evidence of how it helps autoimmune diseases. And then the anti-inflammatory I talked about, so all these factors it can secrete, all the anti-inflammatory molecules, and anti-apoptotic. So it's interesting, let's say somebody got a stroke, and unfortunately the problem with stroke is not just the stroke happened, is what happened to those cells afterwards, that they start dying. They start to tell themselves to die because the calcium and the influx, and so they can't stop it. But the stem cells have the ability to stop that terrible path and rescue them. So like for trauma, hypoxia, any kind of damage, that they're able to rescue those cells, so the cells are not going to die away. And then, interestingly, they also have antimicrobial properties. They actually secrete antibodies. Very interesting. So they have these different peptides. So for chronic infections, also has been shown to be quite effective. So a lot of Lyme disease patients are using this. More and more people know about that. I have a patient who's a very respected doctor. He's actually a leading expert in Lyme disease, and he has Lyme disease himself. So he's tried everything. He tried embryonic stem cells. He tried ozone and peptides. So when he tried stem cells, these umbilical cord stem cells, he noticed a qualitative difference. So this is, he just told me, he said he hadn't worked out for how many years? Quite a few years. So now he's able to actually go work out because he was so drained from the Lyme disease. So it made a transformative difference. So now he's getting all his patients to use these stem cells. So safety. So mesenchymal stem cells, renamed medicinal signaling stem cells, so they orchestrate the activity of the local stem cells. And they produce huge quantities of biomolecules and can be immune suppressive. And they are able to put up this curtain of molecule around themselves that allow the donor mesenchymal stem cells to be transplanted into recipient without immune response. And so they, so these MSCs also help, also release these factors to help reduce the immune response when the body, to fight against the natural tendency to reject certain cells or cells from a foreign entity. So umbilical cord cells, these have, there's the umbilical cord derived stem cells has a lot of MSCs. If you use cord tissue, the cord blood has 0.1 to 1% of mesenchymal stem cells. It's interesting. There are most companies you see in selling perinatal stem cell products are using umbilical cord blood derived because those are very easy to separate. It's just, cells are already in a suspension. They just spin it down. There's not very much trauma to the cells, and so the product is easily made. Unfortunately, they just don't have that many mesenchymal stem cells. The cord tissue, on the other hand, you saw it's a tissue. It's a gelatin-like. It's wrapped around. So those cells are embedded in the tissue. So how do you free them without using enzymes? So there has to be some mechanical manipulation. There's some cutting involved. So they're trying to separate the cells without enzymes because the FDA doesn't allow enzyme to be used. An enzyme does change some properties in cells, by the way. There are cell receptors and different properties. So these cells have gone through some trauma, and most companies don't know how to do it. So I've talked with a lot of stem cell science. Some very respected scientists, they can do cord blood easily, but the cord tissue, they don't know quite how to approach it. So, but the cord tissue is really what I think, where the most valuable components are at. And so MSCs provide immune modulating capacities, can stimulate regeneration. And so these are the advantages of umbilical cord mesenchymal stem cells. And these, because they can be administered multiple times and in uniform dosages. And there's no need to collect the cells through invasive procedure like liposuction or a bone marrow collection. And the cord MSCs, they're more efficient in their proliferation differentiation than other type of stem cells, adult stem cells. So are considered more potent. So the umbilical cord derived cells have been shown to be more potent. And so clinical benefits, so there has been a lot of conditions has been looked at, and these are some of the conditions that the stem cells have been shown to be helpful. So autoimmune disorders, that's a really big one. Neurological conditions, I showed one of the doctors before the talk a picture of a patient, 80 years old patient, drawing a clock that's completely, is barely a clock. All the numbers are lined up like this. So there's a clock and the numbers are lined up like this. So they're not spread around the perimeter. And a month after the stem cell treatment, so the person got intranasal stem cells. When you put cells here, it can be uptaken to the brain, cross the blood-brain barrier, because the olfactory nerves has the ability to uptake them and bring them into the brain. And they've tagged the cells and found the cells from intranasal deposit, and they actually do migrate into the brain. So it's pretty fascinating. So that woman, 80-something-year-old woman, got that treatment. And a month after that injection, the clock was vastly improved. It's making a lot more sense. The numbers actually was spreading around the perimeter. It actually looked a lot more like a clock. It's still not a perfect clock, but the remarkable thing is that we don't have anything in medicine these days to actually produce that kind of benefit. I've treated a lot of Alzheimer's patients, and it's the most you can do is to keep them steady, and it's very little hope that they will get better. And then we have type 2 diabetes, so metabolic syndrome. It's pretty fascinating. So that doctor who had Lyme disease, he actually, as a result, he had metabolic derangement. So his cholesterol was really high. And then after he did the stem cells, they all came back normal. So he was like, wow, this is amazing. So heart disease, I've treated a couple people with heart conditions, arrhythmia, and they were doing great. Vast improvement. This is very common, osteoarthritis. One of the most common things people use stem cells for. Erectile dysfunction, that I have started treating. People do notice, a significant benefit. A lot of people, use PRP. That has been around for a long time. The PRP's effect probably lasts for about 6 months, but the stem cells will last a year or two. So it just lasts a lot longer because these are a more potent product. And these cells do have intelligence that's able to respond to your local environment and secrete what the tissue needs instead of just PRP, just these growth factors and just thrown in there. So there's limitation on how much those growth factors can do comparing to live cells. Dermatological conditions, lung conditions, injuries, autism. So that was the autism. A lot of kids go to Panama to get treatment. So actually, one of our doctors that use, because I also, the product I use, so this doctor used the same product, and this patient had autism and went to Panama and spent $20,000, $30,000 getting the treatment. And when the patient came back and got the treatment using these umbilical cord stem cells, so these, in Panama, it's also umbilical cord stem cells. It's interesting, but they expanded to a huge number, 100, 200 million cells, and they give it back to patients. Whereas our cells, it's only 15, 20 million cells. But after the patient used it, so the family said the kid responded much better to these cells comparing to those. So that's actually a very interesting thing I found out at this conference, new research showing that expanded cells are a lot less potent than native cells. So native means you have never manipulated it, you have never grown it. The expanded cell has been grown in culture, incubated, and they can grow to a lot of numbers. But what they've shown was was a graph where 100, let's say 100,000 of native cells can reach this level of benefit. And you can give 1 million of expanded cells, and the benefit is about this much. So there's still, even at 10 times the number of cells, it's still slightly less potent. So you probably need to give even more. So that's a remarkable thing. That can explain why these native cells that we're using, because we're not allowed to use expanded cells in the US, why that's actually more powerful. That's gotten such great results, even as low as 10 million cells given to people. And then the autism, yeah, it shows tremendous improvement. So I have a lot of research articles on all these conditions. So if there's any condition that you guys are really interested in, just email me, let me know, and I'll be happy to share with you. So spinal cord injuries, wound care, that's been around for a long time. And then anti-aging is interesting. So studies showing that actually they did 3 months, 6 months after infusion, IV infusion, and their skin, hair, energy level, libido have all shown improvement. So that's a general anti-aging. Go ahead. No problem.
Is this all intravenous administration?
Not necessarily. I'd be happy to talk about the application. What I think is the most powerful, a lot of the internal organs, the IV will be important. But if you have particular, let's say, osteoarthritis, you have local injury or neuropathy, particular area, or erectile dysfunction, it's probably better to inject some cells right in the area because you get a huge concentration of growth factors in cells. The IV is going to help improve your entire system. Even osteoarthritis, the inflammation is not just in your knee, it's still throughout your body. So it's always good to address your systemic health. But for a lot of the internal conditions, yeah, that will be IV use. And for small joints, you can't get into the joint space, but they're well perfused. So you can just give IV and that will be taken care of. I've treated a dermatologist with, he has plantar fasciitis. Actually, I think that he got it previously, and it did steroid injections. It took him months to actually get better. And then, so he was limping, and I saw him limping, and then so he said, okay, yeah, let's try this. So he got the stem cells, and within 1 week, it's 95% gone. So you all know plantar fasciitis is pretty tough one to deal with. So the modes of delivery, so there's IV, intra-articular. So intra-articular is important when you have a large joint. So when you have the hip, the knee, shoulder, so these larger joints, probably intra-articular is important when you know the problem is within the capsule. It's actually within the joint itself. To be careful, a lot of people have joint problems, really the surrounding tissue. But if you do have within the knee, then the internal, especially the osteoarthritis, within the big joints. So when you look at the cartilage damage, the cartilage, the outer 1/3 is nourished by the blood supply, but the inner 2/3 are nourished by the synovial fluid. So, if you're just doing IV, it may not address the internal environment as well. So you probably want to give a dose right into the joint space. And then intramuscular, you can do that. Intrathecal, of course, is more specialized. Just not many doctors are willing to do it. That makes intranasal very attractive because that's a lot more comfortable. As far as safety and just convenience. And then there are people under ultrasound, and they can inject directly into organ of interest. So dosing. If you do IV, the 0.5 million cells per kilo body weight will be on the sort of the, nowadays we believe 0.5 to 1 million is the range. So 0.5 is probably the least. I've seen good results with 0.5 million per kilo body weight. So when you look at that, when a person, let's say, is 140 pounds, that's about 63 kilos, and so the person will need about 31, 32 million cells. So the product I use has 8 million cells per cc. Then that means it needs 4 cc. So they just they come frozen, you know, in a vial, or overnight shipped to the doctor's office. So you can just order exactly what you need. So it's very convenient, and of course it's done in a FDA registered and inspected lab, so you know they've gone through everything, you know, the sterility and everything is up to par. So you know, there's this safety, quality control. So that's the dosing. So I have a lot of patients come in to do just for anti-aging treatment. So you know, because these cells last in the body for about 6 months, if they have really aggressive disease process, maybe in 3 months they might notice, you know, some relapse in symptoms. But if they do, you know, they do everything right, they do the right nutrition, they are addressing their hormone issues, or they detox, then their stem cells will, the effect can last so much longer. So I tell them, let's do comprehensive evaluation, because, you know, you're protecting your investment. You know, we can't, you know, this is not, panacea for everything. You're still, you know, you're still a physical body. There's still all these parts and components that you need to address. So, but for anti-aging purposes, you know, just to dial back basically all the inflammation. I'm sure we all have inflammation in our body. So I've done about 10 infusions for myself, you know, every few months or every 3 months or so. So I have patients who are coming in like regimented. They come in either every 3 months or every 6 months, just so that they are, you know, helping their body regenerate and repair, and, you know, prevent the decline. Because what people don't realize is that sometimes when a person is really healthy, they may not notice a lot of difference. But doesn't mean that the benefit is not there. Because just like when we're getting sick, a lot of times we don't even know we're getting sick. All of a sudden, one day it's like, oh, I'm sick. But does that mean that you weren't sick before? A lot of times you were sick, you just haven't hit that threshold. So the same thing with getting better. So you may not know you're getting better, but doesn't mean the repair is not happening. So that's the IV infusion, and so that's how I usually do it. So this is how I was doing it, but this actually it's you know, I've made some modifications. So I'm not gonna. So that doesn't really quite correspond with what the dosing I was talking about. So that was an earlier earlier protocol, but I've updated it because of the new science. So now it's 0.5 million per cc. So you just, you know, when you get the product, so I'll show you the picture. You get the product, so it comes in a vial, and then you thaw it with your hand. You just kind of roll in your hand, because the key is rapid thawing. If you do it too slowly, there can be a certain temperature. There's one particular temperature, I think it's somewhere around 60 degrees, minus 6 degrees, that there's potential for crystal formation. Then it can puncture the cell membrane, it can die. So you want to do very rapid thawing on your hand, and then you draw into a solution and put in an IV bag. So these are the research trials on umbilical cord stem cells, you know, throughout the world. U.S. still leading, and then China is next. So what does it mean as a doctor? So basically, I want to just, you know, impress upon you that stem cells are very powerful tools for regeneration and for you know, as therapy. It has a lot of advantages over traditional, you know, medical approaches, because there's very little side effect, and we're kind of going back to our origin, using what made us. You know, the intelligence that was in the embryo, was in that fertilized egg, is still in us. So these are the stem cells. So what can make us as a human from that one little cell? That kind of intelligence is unimaginable. So if we can use that, instead of trying to throw one chemical, another chemical, thinking that magically one chemical, you know, this chemical just going to do everything, I think that's rather arrogant to think that we can just find a molecule to just do everything. So I think to engage in nature's innate intelligence is really the future of where we should be going. And the power has been amazing. I was telling you know, this doctor at the beginning that how years ago when I was in residency, that was over 10 years ago, the doctor, the neuropsychiatrist, he was going to neuroscience conference, Alzheimer's conference every year, and he said, we're on the brink of finding a cure because the government has allotted all this money. So we have a battle against Alzheimer's. So in 10 years, we're going to find a cure. So it's actually over 10 years. And I don't think we're any better than where we're at. No one has been able to show that kind of results from that patient-to-clock drawing. I mean, that's really inspiring. So that's it. That's my presentation. So I very much welcome any questions.